Very good evening to all of you. I welcome you all for the second academic session by the Epilepsy SIG. Today we have an interesting talk by Dr. Hassan Tebul from Turkey. He will be speaking on the role of genomics data on the concept of developmental epileptic encephalopathies in the ILAE electrolytic syndromes, a reflection from the national cohort study. I would request our President, Dr. Shafali Gulati, to introduce the speaker, today's moderator and the expert for today's session. Over to you, ma'am.
Thanks, Mahesh. As usual, we will be having a wonderful talk by a wonderful expert, and where we will be having two experts in addition to the speaker. And our speaker is Professor Hassan from Turkey, who graduated from University of SIG Izmir, Turkey, and he began his career in pediatrics in 1992, and then as a pediatric neurologist in 1994, and as an associate professor in 1998. In 2000, he was awarded a grant by the Turkish Scientific Research Council Research Fellowship at Harvard University. He studied neonatal neurology with Joseph Volpe and neonatal EG with Gregory Holmes and Bless between 2000 and 2002 at Children's Hospital, Boston. Dr. Hassan has spent 3 months in Cleveland Clinics as well, Ohio, for a 3-month EEG course. He returned in 2002 to set up pediatric clinical neurophysiology lab for the comprehensive diagnostic evaluation and treatment of children and adolescents with epilepsy at the Ege University Hospital. And Dr. Hassan took up the position of Professor of Pediatric Neurology in 2003. And his clinical subspecialties are neonatal neurology, developmental neurology, pediatric epilepsy, and pediatric clinical neurophysiology. And he's doing TMS as well, which are very of interest to us. He has designed and tested a reduced electrode EEG montage for neonatal EEG monitoring, and has contributed to seminal research for the biomarkers for epileptogenesis and neuronal plasticity in developing brain with TMS. His current projects include genetic characterization of developmental epileptic encephalopathies, new EEG modalities for neonatal seizures in neonatal care units. Dr. Hassan has 166 original papers and numerous book chapters. He has presented in innumerable meetings. He's an amazing professional and an amazing individual, and he's heading the Turkish Pediatric Child Neurology Society, and he's an active member of the ICNA. And he was the chairperson and scientific committee member of the Antalya 2022 ICNC. Thank you so much for joining us. And we have two experts today who will be discussing it. One is our with Dr. Gauri, who has been my senior at AIMS New Delhi, and we always felt Dr. Gauri and Dr. Gauri's husband both were very high on cerebral quotient, and she's married an adult neurologist, and I really admire her knowledge and depth for a very long time. Thank you, Dr. Gauri, for joining. And we have Dr. Vinod Skaria, who is a physician scientist, who was initially there in the he was there in the CSIR, institute, but now he has left that and is now a senior consultant, VCCF, and adjunct professor in IIT Kanpur. He has, he's got a very important quality of being a physician scientist. He's one of the very few physician scientists India has, and he has over 2,000 publications and has been the co-founder of the Genomics for Understanding Rare Disease Alliance Network. And thank you so much, Dr. Vinod, who's been for joining. He has been a long-term collaborator, and we have been working on epileptic encephalopathies, autism, and non-DMD muscle dystrophies along with him for genomics. And recently only he moved out, so we are just finishing our data thing. And the moderator for today's session is going to be Dr. Jitendra Sahu, who is our alumni, and he was being trained at AIMS New Delhi, and currently in PGI Chandigarh, and a senior consultant there, and he looks after epilepsy and West syndrome, with his favorite. So epileptic encephalopathy is his favorite, and he is one of the conveners of this SIG. So we had made one SIG member, SIG, we have made two conveners. One is the EB member and the other is a non-EB member. So Dr. Jitendra Sahu is a non-EB convener. And over to you, Jitendra, in between for the Q&A and all the moderation of questions and between the experts. So right now I handing it all over to you, to Professor Hassan. It's all yours. Everybody is eager to, hear you all. And Ranjit will also be a co-moderator, and he's also an alumni. He's a junior alumni, passed in a couple of years back, and he's gone and trained in in Canada, and he's come back after his fellowship from Canada in epilepsy, and he's now in Ramchandra Institute in Chennai. It's nice to have many of our alumni around, but that makes me feel very ancient also, Dr. Hassan. We've had 53 who are my alumni, who are there everywhere. So, so it's nice to see them, but then when they are mentoring them, then it makes me feel quite old, actually. So over to you, Dr. Hassan. Thank you so much. And Dr. Aneja, would you like to say something, ma'am? Dr. Aneja? Dr. Aneja was actually for the last many months in New York, so she's just back in Delhi. Yeah, Dr. Aneja.
Good evening and welcome everybody. And I think we straight away start the session without wasting time. In the pre-Diwali, I'm sure people are, busy with other things. So let's start.
Yeah.
Thanks.
Yeah,
and
thank you.
And glad to join today after a long time. Thank you.
Thank you, ma'am. Professor Hassan.
Good evening, everyone. Dr. Sandeep here.
Good evening, Dr. Patil.
Professor Hassan, you can start sharing the screen.
Okay. May I share my presentation?
Yes, please.
Yeah, thank you. Can you see my presentation?
Not yet. You will have to minimize the browser. Yes, we can see it. Yes.
Yeah. Can you see it?
Yes, you can proceed.
It's great. May I start?
Yes, please.
Please.
Yes. Dear ladies and gentlemen, it's my honor to be involved in this fantastic webinar. I'm really fan of these webinars. When I get the invitation from the president of Association of Child Neurology India, Dr. Shefali, I'm really excited to be involved in these webinars. Thank you, Dr. Shefali. Thank you, Secretary of Association of Child Neurology India, and thank you all the experts and then all the special interest group members and for all the attendants. It's my pleasure to be here and then present my my presentation. My topic is developmental and epileptic encephalopathies in the International League Against Epilepsy Electrokinetic Syndromes. I'm trying to be covered from concept to precision medicine. I constructed my presentation to three separate parts. The first part, in the episode 1, I'm going to focus the role of genomic data on the concept of developmental epileptic encephalopathy and the electrokinetic syndromes. I would like to express our reflections from 2 national sequential cohort studies. And the second part, I would like to focus the genetic landscape of early onset developmental epileptic encephalopathies, neonatal and infantile onset, with our regional cohort studies comparison with the around world other cohort studies. And the final part, episode 3, I'm going to focus precision medicine for developmental epileptic encephalopathies with some illustrative case vignettes, and then conclusion remarks. The episode 1, I'm going to focus on genomic data, provide emerging huge number of gene-named developmental epileptic encephalopathies. Then we are still have some electrochemical syndromes, but we are ignoring some of the electrochemical syndromes. Now in this first part of, I would like to get your attention to the electrokinetic syndromes, based on the new ILEA classification, and then give our reflections from two sequential national cohort study. As you know, electrokinetic syndrome is a term which refers distinct epilepsies of childhood which have peculiar similarities with the age of onset, seizure semiology, characteristic electroencephalography, and similar prognosis. They have different etiologies. ILEA defined a new term, developmental and epileptic encephalopathy. Before this definition, we used the epileptic encephalopathy to describe the causal relationship between epilepsy and developmental delay. Then we used the term of developmental encephalopathies, including intellectual disabilities and autistic spectrum disorders, which are frequently associated with infantile epilepsy with several gene variants. Now we have more than 300 gene variants might be related to epileptic encephalopathies. Then we use developmental and epileptic encephalopathy may be more appropriate than the epileptic encephalopathy. And this term include early onset seizures, often refractory to anti-seizure medication, different kind of EEG abnormalities, some specific patterns, and also developmental delay, regression, and intellectual disability seen in the patient. Finally, we use developmental and epileptic encephalopathy after the ILEA proposal. So this is before this term, we have at the beginning of this 2003, we have a landscape of epileptic encephalopathy around 5 to 10, and then increase the number when we look at the genetic landscape of epileptic encephalopathy in infancy. 2016, we have more than 10. Then ILEA tried to be new definition, some mandatory, some exclusion criteria for developmental epileptic encephalopathy. A substantial number of patients with epileptic encephalopathies do not have phenotypes that fit in the specific epilepsy syndromes. Sometimes we put it in the specific electrokinetic syndromes. They do not have the same phenotypes. So this is a more complex group. Some specific subgroup of developmental epileptic encephalopathies has specific peculiar seizure types. For example, infantile seizures. Most of the kids have infantile seizures, different kind of genetic variants. We try to separate group of the developmental epileptic encephalopathies based on the genetic variants. Some of them still has electroclinical syndrome definitions. We have a lot of patients, and then we try to put all of them a separate subgroup of gene-named developmental epileptic encephalopathies. There is a discussion between the epileptologists and pediatric neurologists where we are going to put all the gene-named developmental epileptic encephalopathy goes to the which electroclinical syndromes. Before going to this discussion, I would like to say some specific words about the etiology. Last year we did a epidemiologic study for the etiologic trend of infantile seizures, digital and genomic eras with 3 chronological periods during the last 21 years. So, you know, we have different developmental epilepsies and then different etiology types. Some of the electrochemical syndromes has different etiology. Single electrochemical syndrome has one or single or more than 3 etiologic subgroups: structural, genetic, metabolic, immune infectious, or some of them unknown. In this study, this is a regional study. We did it in our department. The aim of this study, we use the new neuroradiologic modalities, genomic test and metabolic test, to define etiology, 3 different chronologic ages. We have around 400 cases. Then we created 2 different timescape of this study, and then we did this diagnostic workup for the etiology. We tried to use 1.5 Tesla, and some cases has 3 Tesla cranial magnetic neuroimaging. Almost 90% of the cases had an MRI examination. We identified abnormal MRI results in the 64%. Then I would like to discuss what is the impact of this abnormal EEG on definition of developmental epileptic encephalopathies and the subgroup of epilepsies. Also, we have a metabolomics, and then we have genetic tests. When we look at these chronologic ages in this historical cohort, genetic etiology increased from 16.5% to the 42%, 3 times more genetic etiology we identified in this cohort. Then in this genomic area, you will see the subgroup of the etiologic subgroups. Most of them still also has structural etiology, and second number is genetic etiology. The still unknown etiology in the 3rd round, around 20.4%. 1/5 of the cases are still unknown etiology. When we look at the literature, we identify abnormal EEG, and then also in this Helen Post study, they also define abnormal MRI findings around 72%, and then they also defined that around 51% is etiology relevant. Structural etiology is in this study is similar to our rates. It's around 26%. Genetic etiology is less than ours. This is the newly diagnosis epilepsy of infancy cases. This is at the beginning of this 2010. Our study also included after the 2010 cases. In our study group, also compared with the Italian group, in this study, they also defined the combined structural and metabolic etiology around 55%. They identified genetic etiology around 16%, unknowns still with a rate of 28%. It's another Thailand study. They evaluated 57 infants diagnosed between 2012 and 2018. Neuroimaging was performed in similar to our study. They did MRI examination 68%. The genetic etiology is in this study also around 14%. Now, this is another study, South Korean study. They have a genetic etiology around 6.2%. The genetic etiologic variance number is increasing number during the historical chronologic time. So unknown etiology in some studies, in this study, this is Chinese study, they also have unknown etiology around 48%. This is a Ignoharbic review article. They say that around more than 70 epilepsy-related genes. These all genes explain 20 to 25% of the severe and early onset epilepsy cases. In our study, in this historical cohort, we did separate group before the next generation sequencing and after the next generation sequencing. The genetic variance number increased from 80% to the 17% to the 42%. Then the conclusion, when we use the neuroimaging, genetic assessment, and metabolic assessment, we identified more etiology, and then we can give targeted management for this kid. After the regional study, we designed a national cohort study around the Turkish population, and then this is a step-based approach for etiologic diagnosis for the developmental epileptic encephalopathies. 16 epilepsy centers involved in this study. The main objective to define the etiologic trend, developmental epileptic encephalopathies in a large cohort between 2005 and 2021, and also to evaluate the diagnostic yield of genetic and metabolic investigations in this cohort. This is the inclusion criteria. 16 tertiary centers from Turkey involved in the study. We use these parameters. We define the age of the onset of epilepsy, etiology. We first define the clinical phenomenology and the diagnostic workup, MRI findings, metabolic test, and genetic test. Finally, which cases get a targeted therapy. And also we defined the therapeutic yield of defined etiology was followed, especially in the genetic and metabolic etiology group. In this cohort also we have around 1,200 cases, and that all the cohort get a step-based approach for a definite etiologic diagnosis. In the step 1, we define the clinical phenomenology. In the step 2, we use the neuroradiology for the definite diagnosis. In the second step, we use the metabolic screen test for the specific etiologic diagnosis. Finally, in the first step, we use the genetic test in this step-based approach. Here are our steps. Step 1, clinical phenomenology, detailed clinical history, detailed neurological examination. And then in the second step, neuroradiologic findings separated 3 groups implicating acute, congenital, and genetic etiology. And then we have 2 types metabolic screening for developmental epileptic encephalopathies, basic screening tool and an extensive tool. In the genetic test, we have 2 types of the genetic testing for the developmental epileptic encephalopathies: chromosomal based tests, karyotypes, FISH, and microarray. And then we also use next generation molecular tests, single gene analysis, epilepsy panels, clinical exome analysis, and whole exome sequencing. In this cohort, here is our subgroups based on the different chronological time. So most of the case located in the fourth part of the 2018 to 2021, 28% of the cases located in this period. We define the etiology diagnosis around 60%, 78.8. Most of the case still has the structural etiology. The metabolic test provides a metabolic etiology only 9.2%. Immune infectious etiology in this group is 2.7%. And the genetic, you will see the genetic etiology in this chronological historical cohort study. The exact number of the cases with genetic variant rate increased from 30% to the 42%, 43%. So genetic tests, we use this step-based application. Here are our genetic testing modalities. We use epilepsy panels, microarray, and then whole exome sequences. Some of the cases also has mitochondrial panels. Diagnostic yield of epilepsy panels in this study, epilepsy panels, increased up to 42% based on the structure of the epilepsy panels. Every year we developed our epilepsy panels based on the involvement new variants. And also we defined the diagnostic yield of full exome sequentially. It's a similar, slightly increase from 65% to the 73%. This is a slightly increase. We used second whole exome sequencing and need modalities to define the genetic variant. When we look at our results compared to the previous studies, and then we have a similar rate of the pathogenic variants in our cohort, including just only developmental and epileptic encephalopathies. When we compare the and Merck studies, they used early life epilepsy with genetic testing. Pathogenic variants are similar rates, around 40%. Different kind of diagnostic yield described in the different studies. In a Korean study, they defined the pathogenic variants around 47%. And another study, they've defined the pathogenic variants, similar rates, 40%. And then another study defined disease-causing variants identifies around 22%. There's the diagnostic oddity for developmental epileptic encephalopathy. We define in based on our cohort a step-based diagnostic workup. It's still our main road for the defined etiology-specific diagnosis in developmental epileptic encephalopathies. But some centers may decide their own strategy for the etiology-specific diagnosis developmental epileptic encephalopathy. Maybe logical early application of the whole exome sequencing before the metabolic screening. It depends on the developmental. It's based on the country's position and then economic situations. Finally, step one, we proposed a step-based approach for the etiologic diagnosis of children with developmental epileptic encephalopathies. But we decided dynamic and extensive genetic testing in the new next generation era might provide more diagnostic yield. And then in this study, precision therapy, we applied precision therapy up to 34% of the children with developmental epileptic encephalopathy. What we get to the reflected from this national cohort study, when we look at the cases that only named developmental epileptic encephalopathy, we have a group of patients with developmental epileptic encephalopathies. Sometimes we define electroclinical syndrome based on the EEG and a clinical characteristic. But some of the cases, they don't have a specific electrochemical syndrome, for example, Dravet syndrome. In this study, in the second part of this cohort study, we defined the well-known electrochemical syndromes in this large cohort with gene-named developmental epileptic encephalopathies. What is the intersection between these two groups, developmental and epileptic encephalopathies, gene-named developmental epileptic encephalopathies, and the well-defined electroclinical syndromes? In this cohort study, I explained the first step of the EpiStep. This is a step-based etiologic approachment for the diagnostic workup. And the second step, we have 655 gene-named developmental epileptic encephalopathies. And this compared and then reanalyzed based on the OMIM data-based type developmental epileptic encephalopathies. And then finally, we defined a genetic molecular diagnosis around 90% of the cases with gene-based and then chromosomal-based analysis. And then finally, we separated our gene-named developmental epileptic encephalopathies on the ILEA definition of electrochemical syndromes. In this table, you will see our well-defined electrochemical syndromes, and then how much cases has metabolic genetic, molecular genetic, and chromosomal-based variants. And then if we define a gene variants, a well-defined electrochemical syndrome, we call this is a electrochemical syndrome with gene-named developmental epileptic encephalopathy. So finally, in this cohort, we defined in our cohort, 77% of the case has an electrochemical name and also a gene-named developmental epileptic encephalopathy. TNA1 was the most common pathologic variant in our cohort study. In developmental epileptic encephalopathy cases has different pathogenic variants of the same gene present with different phenotypes and different electroclinical syndromes. This phenotypic heterogeneity might be related to the epigenetic factors, timing, and the location of physiologic gene expressions, and then modified genes. When we look at our cohort, only 30% of the cases are specific identification on the OMIM database. The remaining around 69% of gene-named developmental epileptic encephalopathies in our cohort still do not name in the OMIM database. And the conclusion and the reflection of this true sequential cohort study, we reflect the importance of the electrochemical syndrome may be reduced in the favor of new genetic tests. And then we proposed the term gene-named developmental epileptic encephalopathy, for initial diagnosis for the clinical entity for still unknown electrochemical syndrome. Maybe in the follow-up, electrochemical name may be involved, the gene-named developmental epileptic encephalopathy. This kind of definition may be better than genotype and phenotype correlation. This is my second episode of the presentation. We look at our genetic landscape of early infantile and neonatal seizures based on the molecular specific diagnosis for a therapeutic aspects of the outcome in a regional cohort study. You know, the etiology for the neonatal onset seizures and infantile onset seizures is most of them asphyxia, related to the asphyxia around 40%, and the poor outcome based on the neonatal seizures epidemiologic studies. We do metabolic screening. Most of the time, we consult neonatal seizures with metabolic specialists, and then ELA defined a new seizure classification for the neonatal seizures. Maybe implication of the etiology specific diagnosis. We use this classification to define, to suppose an etiology specific diagnosis, but we have also still have some problems to use to the ELA neonatal seizure classification. Most of the neonatologists still are also unfamiliar this kind of neonatal seizure classification. So we increase the availability and then use of this new classification with our colleges, neonatologists together, and all the pediatricians. In this cohort study, this is a regional cohort study. It belongs to my institution. We investigated the genetic landscape of infantile epilepsies, and also to make a genotype and phenotype correlation for infants and neonatal seizures to define the diagnostic and therapeutic yield of genetic tests. In this study, we have 133 patients with neonatal onset gene-named developmental epileptic encephalitis during the 10 years old periods. So here are the inclusion and exclusion criteria. These are our study parameters. We did genetic tests, and then we defined the pathogenic mutation and treatment response to the precision therapy. This is our departmental genetic test workup. We use a dynamic genetic testing. We use the first genetic testing, karyotype, macroarray, or epilepsy panel. Then we order the second genetic test based using a genetic counseling with our geneticians after a pediatric neurogenetic case management consult. In this study, most of the case had a seizure, and then seizure between 2 months to 3 months to 36 months of age, and then around 15% at seizure start newborn period. Here are our metabolic and genetic etiologic workup evaluation. And then in this study, we use 72% had a molecular genetic diagnosis using a next generation sequencing. The remaining has a specific diagnosis with chromosomal test or multiplex ligand dependent prompt applications. Here's our results, a genetic test, and then we have molecular diagnosis, specific molecular diagnosis with genetic testings. In this group, we have most of the cases has a functional loss of the variance. It's around 70%. And then also we have cases with cellular proliferation defects on 12% and around 4% of cell migration defects. Finally, in our cohort, we defined SCNA1 mutation. It's a big group, and then we compared to the other groups. Also has a similar result. SCNA1 is the #1 genetic variance in early onset genetic epilepsies. Based on this regional cohort study, we thought that genetic aspect change over time. Genetic tests available for most of developmental epileptic encephalopathies and idiopathic epilepsies. In this respective study, we extensively genetic tests in children with infantile epilepsies provided more diagnostic and therapeutic yield. When we look at the case developmental epileptic encephalopathies. The number one syndrome is the old name is West syndrome. The name based on the new ILIA classification, infantile epileptic spasm syndrome is a severe epileptic encephalopathy, and this group has more than 40 genetic variants. So we today we are trying to be precision therapy for infantile epileptic spasm syndrome based on the gene based on the gene variant. For example, if we define tuberous sclerosis gene, we start earlier as usual. We use then vigabatrin, and then in this sometimes we use combination therapy, vigabatrin and hormonal therapy. When we look at our infantile epileptic spasm syndrome in this genomic area, we defined a new etiologic trends and then yields of genetic tests. In this study, we did etiologic definition based on the genetic structural, and structural congenital, basic structural, and metabolic, immune infectious, and unknown. In this study, our objectives to define etiologic trends of infantile spasm in this genomic area with a step-based approach in this cohort. This is our regional cohort. It is different from our national cohort study, and also we evaluate the yields of the genetic test metabolic investigation for the therapeutic approachment. So in this cohort study, here is our inclusion and exclusion criteria. E.g., criteria is the mandatory, hypsarrhythmia, modified hypsarrhythmia, or multifocal or focal epilepsy and electroclinical spasm. This is the mandatory criteria for the involved in this study. In this cohort study, we also evaluated the etiology-specific diagnosis and the metabolic screening. Here's our result, and then when we use our cohort, this step-based approach for the definitive etiologic diagnosis, we have 314 children in this cohort. The genetic testing in this our regional historical cohort study, the genetic test provided definitive etiology around 42%. The rate increased from 9% to the 42%. This is, and also another one important results in this study. This is diagnostic yield of the genetic testing results in our study, and with the development of the next generation sequencing, the rate of structural genetic etiology group increased in our cohort study. And in this specific subgroup of developmental epileptic encephalopathy, I mean in infantile epileptic spasm syndrome, the old name West syndrome, diagnostic yield of epilepsy panels developed from 7.6% to the 19.2%, and also diagnostic yield of whole exome sequencing stayed at the same level. It's around 55%. Here's our genetic result and genetic variants based on subgroup classification of infantile epileptic spasm syndrome. We define the subgroups based on genetic structural, genetic metabolic, genetic chromosomal, and genetic molecular. In this, the therapeutic yield of genetic testing was 26%, including the tuberous sclerosis group. In this genomic area, we have 5 tuberous sclerosis patients with a therapeutic yield. In the second genomic area, after the 2014, we have more gene name variants for West syndrome, infantile epileptic spasm syndrome. And based on this conclusion, we propose that, again, a step-based approach for etiologic diagnosis with cases, etiologic evaluation for infantile epileptic spasm syndrome. But we also use dynamic and extensive use this testing, next generation sequencing, provide more diagnostic yield and precision therapy with children with infantile epileptic spasm syndrome. Now, in the next 5 minutes, I would like to focus our developmental epileptic encephalopathies starting in the late infancy periods. One of them is the epilepsy with myoclonic atonic seizure, EMAS syndrome, is a cohort study. This is, this is the EMAS, the old name is Duze syndrome, is constitutes 1 to 2% of childhood epilepsies. This is another developmental epileptic encephalopathy, latency period developmental epileptic encephalopathy. The diagnosis is a challenge in this developmental epileptic encephalopathy. The diagnosis is clinical, combined seizure semiology and other historical data of EEG feature. There are no widely accepted and well-defined criteria for EMAS group. Then there is also an overlap with this developmental epileptic encephalopathy with other epileptic encephalopathy, mostly in the Lennox-Gastaut syndrome. And then there is a positional table for EMAS from ILA 2022, where there are some mandatory and exclusion criteria. Then the differential diagnosis of the pure EMAS syndrome is basically require extensive neurophysiologic studies for the EMAS group. Last year, there was a Delphi study reported based on the electrokinetic feature of the patients of the EMAS syndrome, and then the recent Delphi process established foundation and this terminology and criteria that are critical for future research in the EMAS group. We evaluated our 30% of cases of the EMAS group based on the Delphi consensus. We presented it in the last year, 2022 International Child Neurology Congress in Antalya. This is the group seizure type, and then this is the MRI examination. We did genetic analysis. 1/3 of the cases, all the cases are normal, so EEG examination, and then in the follow-up, only 32% had a normal development. The rest of them mildly, moderate, or severe cognitive outcome. So early interventional therapy is also important for the EMAS syndrome. Finally, in this my final part of the presentation, I would like to focus a few 5 cases with developmental epileptic encephalopathy based using an electrokinetic syndrome to the precision treatment with some illustrative case background. In the neonatal epilepsy syndromes, we have 2 most popular neonatal onset epilepsy syndrome: early myoclonic epileptic encephalopathy, early infantile epileptic encephalopathy, erratic movement like the first months of life, the duration of the spasm, 3 to 5 seconds, also has some focal motor seizure. It has a myoclonus, starting with first month of life in the NICU, and also baby has infantile spasm at 2 months of life. All the metabolic screening was normal. EEG examination also birth suppression pattern. We did a lumbar puncture, and then we had a diagnosis of non-cathetic hyperglycemia. With MRI, also had a corpus callosum agenesis on this sagittal view. In this case, we have a seizure activity. This is a kind of subtle type seizure. Second, based on the Warbeck classification, we call subtle type seizures, or Neve-Ilia neonatal seizure classification. We did autonomic seizure, automotor seizure. So we use phenobarbital, levetiracetam for the treatment of seizure, and physical neurological examination revealed to us microcephaly. Baby has also multiple large vascular malformation hemangiomas at the right forearm and then hemithorax and right abdominal region. EEG has burst activity, not burst-like suppression. There are some suppression period. This is not typical burst suppression pattern. We did MRI examination. MRI revealed that polymicrogyria, malformation cortical dysplasia, diffuse cortical dysplasia, and then kid has we did all the serologic screening and metabolic screening and chromosomal analysis. All of those are normal. And then based on the MRI examination, we did a structural and genetic diagnosis based on megalencephaly, capillary malformation, polymicrogyria syndrome, using the major criteria and minor criteria, and then somatic mutation revealed this pathogenic variant. Finally, we decided we classified the babies. This is epilepsy classification by type, unknown, and then epilepsy with etiology, structural, genetic, and based on the ectoclinical syndrome, we defined the Ohtahara syndrome. In this case, it has some sequential seizures. I cannot open the videos, and then MRI examination was normal, no any abnormality. EEG had multifocal epileptic discharge, and then sometimes burst suppression-like pattern. It's not typical. We cannot call hypsarrhythmia, and then whole exome can't read the KCNQ2 heterogeneous heterozygote mutation. So we defined the KCNQ2 encephalopathy for this kid, and then today we have two separate group of KCNQ encephalopathies: benign familial neonatal seizures, and then severe encephalopathy with burst suppression pattern, transient MRI abnormals. We didn't identify any abnormal MRI abnormalities. Early and effective treatment is the kind of precision therapy. We used carbamazepine and phenytoin for this kid with a successful treatment. This is my maybe the fifth final cases. The case has some seizure activity, myoclonic seizures, and focal and non-motor focal seizure activities. And then we did a epilepsy panel to ACN1 frameshift mutation. We did a Dravet syndrome diagnosis. In my last part of the presentation, I would like to give some conclusion remarks. Today we have more than 30 anti-seizure medications, but most of the cases, around approximately 20 to 30% of the cases with epilepsy have drug-resistant epilepsy. We choose optimal anti-seizure medication based on the epilepsy type, or maybe the electrochemical syndrome. The other issue also, we use patient-related, drug-related, and regulatory issues. And then we have some guidelines. Some guidelines based on the seizure type, based on the generalized tonic or tonic-atonic. And also we have first-line drug, adjunctive drugs. We have in the back in the guidelines, we don't use any these drugs, this kind of seizures. So we use anti-drug medication based on the seizure type, and also we use epilepsy syndromes, well-defined electroclinical syndromes, and then we choose drugs. And then ILA, here's the ILA evidence label anti-epileptic drugs based on the epilepsy syndromes. Today we have evidence-based definitions, but we have a few class 1 studies for each electroclinical seizure types, electroclinical developmental epileptic encephalopathies as well. We have some epileptic encephalopathies based on the mutations, where we choose the treatment selections based on the precision medicine therapy we apply. Here are the 5 numbers of the developmental epileptic encephalopathies. We use the precision medicines. The number is increasing. There's another discussion about also which treatment is a precision medicine, which is just only alter the medication therapies. And also this group getting a great attention. This is a Gattore and Tor group, also, and especially in the developmental epileptic encephalopathies, the DC5 and then NPRL2 and NPRL2 variants. There is a mosaicism on the brain. I think in the next 5 years, we are going to make a great clinical challenges for the mosaicism of developmental epileptic encephalopathies. This is my final slide for the presentation. I think today we have more than 400 gene-named developmental epileptic encephalopathies. We have well-defined electrochemical syndromes, around 10. So we're trying to put them together, and then sometimes we get them separated each other to make a syndrome-based therapy or precision-based therapy. Some electrochemical syndromes need first electrochemical syndrome-based treatments. Some genetic tests, some genetic gene-name developmental epileptic encephalopathies need an early application of precision therapy. So we need a elephant memory database, or we need an artificial intelligence application for this. Remember the cases, which cases has a gene name developmental epilepsy, what kind of variants we have, which cases has also gain of function and loss of function. We need that elephant memory database for the developmental epileptic encephalopathies. Thank you very much for your kindly attention to my presentation. Here's my team. You maybe met them in Antalya last year. It was a fantastic meeting for us to see a lot of Indian colleges in the Antalya. We are the number 1 country in the ICNA meeting, because we are the hosting country, but the second biggest number come from India. We did a specific group in our Congress, and then thank you very much for your attending last year International Child Neurology Congress, and then thank you very much for your invitation for this webinar. Last week I was in Kerala. Some of the friends and then some of the members remember me. I was really had a great experience, and then I was very happy. All the time I was happy in India. Thank you very much for your attending, and then thank you so much. Have a great day and a great night. Thank you, Dr. Shefali. Thank you, all the team.
Thank you, Dr. Hassan.
Thank you.
Thank you.
Thank you very much.
Yeah, I will now request the experts to say something. If Jitendra is there, or Ranjit, and the Q&A, you can ask people to put the Q. Nobody has put questions. They can please. Ranjit, can you please take over?
Dr.
Jitendra is not there. Dr. Jitendra, please take over. I didn't see that. That's what I'm saying. Dr. Jitendra, please take. Yeah. Please, everybody can write the Q in the Q&A part, right? Or the chat. If anybody wants to speak, can they raise their hand? They can be upgraded. That's no problem. Yeah. You there, Jitendra? Please speak. Yeah. Dr. Gauri?
Yeah.
Your comments. Yeah.
I want to congratulate Dr. Hassan for such an excellent talk. It was excellent, and he's done a wonderful job. The whole study was so good, a very large cohort. And I agree with a lot of his findings that even in our practice over the last decade or so, we are slowly coming to realize that the yield of genetic testing is probably better than the yield of sequential metabolic and multiple metabolic and multiple metabolic tests. And I suppose he would agree with us. There are a lot of cost-effective analysis which have been published in the last couple of years, in which they've analyzed whether it saves time and money to do a direct exome-first approach compared to that stepwise, very cost and time-intensive tests of all the metabolic tests. What do you say? In today's practice now, I would often quickly do an exome first. That was my first question. The second question was, what I find in today's exome analysis, where they're picking up CNVs much better, is it really worth doing a CMA or directly doing a whole exome? The third question is, do you have any experience with the rapid WGS, the whole genome sequencing, especially in the neonatal period? Dr. Hassan.
Thank you so much, Dr. Guri. Excellent questions. We are still challenging this question in a clinical practice. So my experience, step-based approach is the first step. And yes, when based on the cost-effectiveness studies, we have to be ordered whole exome sequences first. But we have also a lot of whole exome sequencing negative results. So then we need clear definition for electroclinical syndromes and then some metabolic screening and metabolomic studies. So we have to be balanced between testing in our diagnostic workup. So it's maybe due to the semiology first, and then syndrome definition in the second step, and then basic metabolic screening maybe provide to us 6 to 9% of the etiology-specific diagnosis. I accept that, but we have to create our own diagnostic workup based on our country position. And the third question is rapid whole exome sequencing for the neonatal seizures. Yeah, we are trying to put in our neonatal intensive care unit, but it will be in the future. But I think we need more cases and more core study results for the early application of this modality on the neonatal intensive care unit.
Thank you, Dr. Hassan. And what is your feeling about your yield in the chromosomal microarray? Today's exome sequencing pick up most of the CNVs. I don't know whether it's worth doing a CMA and then sequentially doing a whole exome sequencing.
Yeah, I think clinical phenomenology is also important for this decision. If the kid has some clinical phenomenology based on the some genetic clues, we order chromosomal-based tests first, and then we pass to the next generation sequencing analysis.
Thank you so much.
Thank you so much.
There are some questions in the chat. There is a question from Dr. Vivek Barun. When should we consider a metabolic etiology in early onset seizures? Any clinical clues?
Can I get again the question, Dr. Guri?
Yeah, his question is, what are the clues to suspect a metabolic disease in early onset seizures?
I know metabolic clues.
Yes.
Yeah, it depends on the your metabolic screening. If specifically asking about the laboratory clues, yes, we have some screening for blood analysis and then sugar levels and then blood levels of the other metabolic tests, and also metabolic decomposition and some skin eruptions for clinical based. So, and also some metabolic decomposition or organomegaly on the clinical examination. Maybe clue for the metabolic screening first. In our departments, in our workup, we use basic screening first. If we couldn't find any abnormal results, we used an extensive metabolic screening, including CSF analysis in the second step.
Thank you. There's a very nice question from Dr. Jitangi from Sri Lanka. If a baby with a metabolic disease such as biotinidase deficiency develops infantile epileptic spasm syndrome, would you treat with biotin or with standard first line such as steroids and vigabatrin?
Thank you very much. Please pass my hi Jitan. I remember her from my congress, and then I was in Sri Lanka. I'm really fan of her papers about the infantile epileptic spasm syndrome. It's a great question. We use together combined therapy. Today we don't use a standard first line therapy. We started sequential therapy. I mean combined therapy. We started first vigabatrin first. If we didn't get any results to seizure control in 1 week, so we start steroid and vitamin C together. This is a sequential therapy. We don't use a standard first line therapy, vigabatrin first, steroid first, and then if a kid has a biotinidase deficiency, put the biotin on the cases drug list, and then we apply biotin in the same. We don't wait to just steroid and vigabatrin. We used combination therapy with vitamin, biotin, and steroid and vigabatrin combined therapy.
Thank you. There's one question from Dr. Bidisha Banerjee from Bangalore, and she has asked for whether you have any experience of ganoxolone in CDKL5.
Actually, I don't have an experience. There are some literature-based studies. I am expecting some result in the future, but I don't have any experience about ganoxolone. Based on the epileptogenesis-based treatments, I expected some good results for these drug modalities, but I don't have an experience.
Thank you.
Gauri, can we ask Dr. Vinod Skaria to answer the questions you were saying about the CMA and all, Dr. Vinod, because he, Dr. Vinod.
Thanks, Professor.
Yeah, which test when? That was important.
Yeah, you know the answer, and Dr. Gauri rightly sort of mentioned that at this point in time, while cost is really an issue, I think, like also stated by Professor Hassan, a whole exome sequencing would be the first right genetic test. Of course, whole exome sequencing is not as good as a CMA, but for most practical applications, for large copy number changes, it could be a substitute, because copy number changes could be very well ascertained on an exome sequencing. Now, what an exome sequencing really lives out are copy neutral changes, which there is practically no way to do without actually doing a whole genome sequencing. So the real hope is we will have a whole genome sequencing as affordable as a whole exome sequencing, probably a year and a half away. And I think that is possible not just in India, but also across the world. And that, I think, with the high rate of genetic pickup that Professor Hassan has sort of mentioned, would really be a game changer for epileptic encephalopathies.
Thank you, Dr.
Professor, I
Dr.
had one question.
Yeah.
So, Professor, you had mentioned that you have a very large or a very high percentage pickup rate for genetic causes of epileptic encephalopathies in your cohort, and you've consistently shown that over and over through the multiple studies. So, is this something also related to the population structure that you're looking at? Like, for example, a higher level of consanguinity, which can contribute to a much higher genetic cause? Because this high pickup is sort of much larger than what you see from other publications across the world. Would you have some comments on that?
It's a great question for our cohort. When we started this cohort study 2 years ago, we easily ordered all the genetic tests to all developmental epileptic encephalopathies. This is why we pick up more cases. The government supports us, and then each case has our own, sometimes family running before us. They are asking to genetic genomic testing. This is why they increase number. And the other part maybe our geographic and social differences from the other countries. We have also more metabolic etiology-specific developmental epileptic encephalopathies compared to other countries because of consanguinity. Thank you.
Thank you very much. Thank you very much.
Dr. Aneja, Dr. Goraya, Dr. Kunhare, all of you, please make comments, please. Dr. Manish Parekh, everyone.
Hi, Dr. Goraya here.
Yes.
It's a wonderful talk, Dr. Hassan, and you have covered, I think, starting from the pre-NGS era to the current era of genomic medicine and precision medicine and treatment. I have a question for you. This is a very heterogeneous group of disorders and with genetic underpinnings. And in the era of precision medicine, there are certain anti-epileptic drugs which are kind of not very effective, but they're effective in treating certain kind of the genetic developmental epileptic encephalopathies. But at the same time, they can aggravate the other kind of genetic epilepsies. In the beginning, we don't know which kind of genetic mutation it is. Is it a kind of missense or gain of function or loss of function? And we end up giving some medication which can actually aggravate. So are there certain anti-epileptic drugs which are a big no-no for all these genetic epilepsies? Or is it just a hit and trial and in the end you kind of modify your treatment once you have a genetic analysis with you? I hope you understood my question.
I think, yeah, Dr. Chettinger, thank you very much. Nice comment. I agree with you. Today, we have cases which we are applying to precision therapy drugs. I think this is not a real precision therapy. So some cases we escape drugs based on the genetic variants. Sometimes we put the drugs, change something. This is not a disease modification, and also this is not a anti-epileptogenic treatment application for gene-named developmental epileptic encephalopathies. This is another debate. You also mentioned that we have to be separate the treatment results of the cases based on the what kind of precision therapy is a real precision therapy. So we need a clear definitions for the cases, which is the real precision therapy.
Possibly everolimus, when used in tuberous sclerosis, even before the spasm start, that study showed it can modify the, that's a little like an anti-epileptic, probably anti-epileptic, probably changes the course of-
Anti-epileptogenic,
yeah.
it is probably anti-epileptogenic. The initial one, the follow-up before the seizure only, right? Before the spasms.
The study in which the EEG abnormalities appeared, but there were no seizures. And everolimus changed the course of their development.
Actually, Dr. Guri, you are right. In our cohort also, some of the drugs make a anti-epileptogenic effect, modifying the disease. Everolimus is one of them. But we put our tuberous sclerosis case on the precision therapy side, but we are not happy about to be put them. Then we decided to apply the everolimus therapy or vigabatrin treatment as an anti-epileptogenic drug before the genetic variant definition. So this is a structural based epileptogenic disorders. So I agree with you. Anti-epileptogenic effects of the everolimus put these cases on the precision therapy group.
There's a question from Dr. Sandeep Patil. He runs a large epilepsy surgery center. In which genetic DEE would you consider epilepsy surgery?
It depends on the etiology specific diagnosis. We have major cortical developmental malformation of cortical dysplasias cases, structural etiology specific diagnosis of developmental epileptic encephalopathies. We use the epilepsy surgery for the genetic structural base of developmental epileptic encephalopathies. Based on just only single gene variant related developmental epileptic encephalopathy, we didn't any cases. We do VNS therapy, and sometimes we used callisotomy before getting the genetic results. So this is not good. But in the future, I think I mentioned my last slide, mTOR and GATOR ways maybe involve some focal malformation of cortical dysplasias with mosaicism. We need in the next 5 years, we use some brain biopsy, some liquid cerebrospinal liquid biopsy for the define the mosaicism on the malformation cortical dysplasias, for example, that DC mutations for the elimination of GATOR pathways.
Thank you.
Thank you, bye.
Can you?
So, so a fantastic talk, Dr. Hassan. And
thank you very much, Dr. Manish.
So I had a question. In fact, I was always wondering, as time progresses and more discoveries are being made, we understand that epilepsy is more of a network kind of thing, which involves a lot of networks in the brain. Did you ever look into the fact that how different genes interact, or maybe a single, a genetic abnormality would result into something abnormal in the networks, and the interplay between the genes and the networks resulting into these epilepsies, which make them, most of them are resistant.
Thank you, Dr. Manish. I think, Was he connected or disconnected?
Who have these abilities, would I like to see? Yeah. So would I have something, which tells me about the network hypothesis in these genetic abnormalities?
Thank you very much. It is an excellent question, and then also future direction will be focused on the network hypothesis. We have an epileptic networks. Epilepsy and also developmental epileptic encephalopathies is a network disease. It is clear. So in the future, I think we are going to be analyzed structural, functional connectivity and functional connectivity based on the EEG connectivity in the future. In the future, we are going to define some structural connectivity and functional connectivity of the brain using the functional neuroimaging and the diffusion tensor imaging. And then other side, we use new EEG modalities to define the epileptic networks on the brain. Actually, we had a study. We have just started at the beginning of this year. Hopefully, we will present it in the Cape Town next year in International Child Neurology Congress. We looking at the two groups, developmental epileptic encephalopathies network analysis using the EEG and functional neuroimaging studies. First group, we are looking at developmental epileptic cancer with electric status surveillance SS group. This is a different kind of network on the brain. In the other part, developmental epileptic encephalopathies, for example, syntaxin-binding protein deficiency or any other subgroup of molecular and genetic-based developmental epileptic encephalopathies, has almost completely different networks based on our functional MRI studies, resting fMRI, and diffusion tensor imaging using the EEG-based connectivity. We are continuing. So far, we have 6 patients in the SS group, and then 6 patients in the early onset developmental epileptic encephalopathies. We are trying to compare the late onset developmental epileptic networks and the early onset developmental epileptic concepts. You know, just only 15 or 20% of the cases of SS group has gene-based developmental epileptic encephalopathy. This group, almost all of them had gene-based developmental epileptic encephalopathies. So, and also if we define a specific pattern for the epileptic networks, we maybe treat our cases based on the specific patterns of the epileptic patterns on the brain, EEG patterns and functional neuroimaging pattern. I think future treatment modalities will be directed on the epileptic networks modification in the future. I think maybe next 5 years we need different. For example, we maybe use some mRNA based drugs for the epigenetic factors involved in the construction of the new or malformated networks on the brains. And the other side, this group has another networks. This is a cognitive networks. Yeah, not all the epileptic networks has a cognitive malformation. So I think in the future we are going to define different networks, different developmental age-related developmental epileptic encephalopathies. Thank you so much.
That was a great answer. Yeah, definitely. We need the future stands here because tactography and the functional imaging should be able to sort this out. I know there are no clear-cut answers, but thank you so much. That was a great.
Thank you so much. Thank you very much. Great question, Dr. Manish.
Thank you, Professor Hassan. It has been an amazing talk. Yeah, and there are going to be newer therapeutic intervention targets coming up. Yes, with genomics and with functional studies and all. You think for your final message before I ask anybody from with the experts, Dr. Gauri and Dr. Vinod, to give their final message, and anybody from the SIG wants to speak anything, Dr. Sujata, Dr. Jitendra, Ranjit. Anyway, and Dr. Gauri and Dr. Vinod, you can give your final message because we are coming to the end. But the final message will be by Professor Hassan. Dr. Gauri.
I think final message is that genetics is going to transform the work of pediatric neurologists. Over to Dr. Hassan.
Yeah. Before Dr. Hassan, now Vinod Skaria is there. Now, Dr. Vinod Skaria, when is your personal genome coming? We had a talk. He took a talk for us on personal genomics, whether it's a reality. That was an interesting talk. You can see the recorded one. Dr. Vinod?
Yeah, Professor, right, like you rightly said, Professor Hassan's talk today has sort of made me really happy in the sense that this is indeed the reality of genomics and personal medicine. A genome for every child is not far away.
Yeah. Mahesh?
It was really a nice talk by Dr. Hassan. Try to cover all the aspects of different type of DE and neurological symptoms. It was really a comprehensive talk. I had one comment, like when you get a VUS on this clinical exome or whole exome, and you don't have any similar cases reported, how do you go about counseling them? Because most of the time we can't do any functional studies also. How do you counsel these families?
Dr. Manish, sorry, I'm a little bit confused that I really don't understand. Could you please explain again?
When you have a VUS, which is a novel variant, not reported in the literature, and we're not able to do any functional studies, so how will you counsel these families about the pathology?
Yeah, I see that. For the functional studies, you mean? For the we asked them for the developmental epileptic and so for the catastrophic epilepsies, we explained to family we are going to get a resting functional MRI study. They easily accept that. This is for the functional neuroimaging studies. We are not given more radiation. This is not a big ethical issue. So the biggest problem is the acceptance from the pediatric neuroradiology departments. They don't want to be involved this kind of studies during the routine their daily studies. So we don't have problem with the family, and then we don't have any we don't get any problem for the ethical side. We get easily from the ethical acceptance from our ethic committee. So the biggest problem for the adaptation of the neuroradiologists to the Connectome project. If you don't have an experienced pediatric neuroradiologist in your department, it is really hard to construct this kind of project. We get a support from the Sweden side, and then we have a Turkish guy living in my center, and then and also if we are doing a disease-modifying drug, for example, for a corticosteroid pulse steroid therapy every month for SS studies, SS cases, they easily accept to what's going on their brain, what kind of changes, some molecular change. Diffusion tensor imaging give us some clue. So if we try to define the results, I think we will apply these results to the modification of our corticosteroid treatment modalities for these cases. We don't have any problem with the family side. the problem arises from the interpretation of the not EEG side, neuroradiological result side. Thank you.
Thank you. Any last words from any SIG members? Okay. So I really thank on behalf of AOC and Professor Hassan, and I think I'll tell you what, we have our main festival Diwali on this Sunday. So this is a very, I mean, it's a festival week. Still, we had 150 people who had joined in the week time, and so that is, and then it will be recorded. It is recorded, so it will be there. So I think it was really very interesting and very nice, and I think it will be very important. And we are grateful to you for having come. Your final take-home message, please. I really like to have a one-time final take-home message from our experts and speakers, and then we can call it day.
Yeah. Dr. Shefali, this is the best pleasure. I get a pleasure from this meeting. A lot of experts. I did several webinars. You are talking some things. You maybe get some questions from the audience. This is the first time I have been a webinar with special interest members, experts, and some moderators. I really enjoyed that. I really enjoyed, and then thank you very much. Thank you very much for your invitation.
Thank you.
Thank you.
I think this should be the
thank
beginning
you
of our
all
association.
the members for time to be here and then make comments and make some questions, do some questions. I really enjoyed that. Thank you so much.
Thank you. Thank you so much. Look forward to more collaboration. Thank you.
Okay.
Thank you so much.
See you. Bye-bye.
Thank you. Thank you.
Bye. Thank you. One
Bye-bye.
thing, we have this annual conference coming of Child Neurocon in CMC Vellore. So please keep your 8th, 9th, 10th blocked, everybody. I think Sangeeta has logged off. I wanted her to speak actually. So we should next time put beginning and end both, right? Okay. Yeah, please. Thank you. Thank you so much.
Thank you.
And happy Diwali. Yeah. Thank you.
Happy Diwali. Happy Diwali.
Thank you,
Bye.
everyone.
Happy
Thank you,
Diwali.
everyone.
Bye.
Diwali.
Bye.
Thank you.
Bye.
Thank you. Happy Diwali.